Annie Alaniz, originally born and raised in Malawi. And I'm a gynecologic oncologist now, and I'm based in Houston. So I would just start sort of the presentation. So I'm actually the oldest of 8 children. I grew up in a very small village outside of Salima, Malawi. And so, I would be your typical girl that grew up in a village in Africa. So this is, actually that picture that you see there was the village where I grew up in Tonje. Most of our lives, things we carried on our heads, as you can see, the ladies over there. I attended most of my primary school pretty much under a tree, like you see the group of kids under there. And really the fastest transportation outside of Tonje generally was like you either take a bicycle, taxi, or carts. And, I spent most of my life essentially, running to school. Water sources, we pretty much would get our drinking water from, the river, same places where the goats were drinking, you were taking your baths there. There were times during droughts where we would actually have to dig through the sand to be able to get our drinking water. And so on the right side, the picture there, you see those are my kids who are very American. Every now and then we'll go to the beach and I'll watch my kids kind of dig through the sand to find water just for the fun of it. And so, it's such a different world seeing that, my kids do that for fun. And I used to do it just to be able to get water for drinking and washing. Episodes of hunger were very often, this is a very agricultural society. So if we didn't have any rains, there were times where people were actually out of food. This is actually a picture outside of, the village where I grew up, where, there was a year where there was a drought, and there were people and volunteers that came in just to give out, corn. A lot of kids have to grow up really fast because of the high rates of maternal mortality. You'll find a lot of siblings essentially having to take care of, each other. So, generally the oldest girls can sometimes be trained to pretty much become mothers in the event that their moms die often, during childbirth. In 1994, I had an opportunity of a lifetime. There was a woman from just outside of Weatherford, Texas, a very, very tiny town in Texas called Poolville, Texas. She actually came to Malawi for short-term medical missions. She, thought I had a lot of potential. I was interested in going to medical school, but just looking at the situation where I was growing, she knew that was not possible. Malawi didn't even have a medical school at the time. It would mean I would have to have like the chance of a lifetime to get a scholarship, maybe to go to the UK. And so, I equate this to winning the lottery, and so she came back to the US and wrote my parents and asked them what they would think if she gave me a private scholarship and brought me to the United States. So actually on July 4th, I landed at Dallas-Fort Worth airport to essentially start my journey in the United States to pursue education into medicine. So it was, like I said, for me, coming from a village, the stories of people coming from nothing, the rags to riches stories, you don't hear as much of those just because of such, gaps in, economic gaps that exist in this society. So that was an opportunity of a lifetime for me. And so, that's where my journey of now becoming, gynecologic oncologist who's now living between, Malawi and Texas, Malawi and the United States comes in. So I was just going to share just a few sort of comparisons. Malawi's population is about 18 million compared to about 29 million. Life expectancy, as you can see it. One of the most sobering, parts about this is like when you look at that median age of 16.8. 70% of the population in Malawi is under 30. So again, that just tells you how, people are not living very long and they're dying really young. And 74% they live below the poverty line. They're making about $1.25 a day. So what are the challenges in healthcare that we see in Malawi? So like I talked about before, access issues are very common. And often this is just associated with being able to get from point A to point B. 90% of the population lives in the villages. And so they're traveling, again, bicycle taxis, ox carts, or they're walking from one place to another. So even in seeking medical care, they have to walk very long distances to be able to get to, healthcare centers or district hospitals around. Often when you go to the hospitals, waiting rooms are very crowded. The doctor-patient ratio in Malawi is 1 to 50,000. So the average patient is not actually seeing a physician. Often they're seeing equivalents of what will be like a nurse practitioner or a PA. Surgical services are, very minimal to non-existent. Often, if there's a surgeon that's going to come to like a district hospital, for example, they may come once every 6 months. And so you can imagine people wait years to be able to even see a surgeon. That's if they make it, depending on what their conditions are. Did I lose the? Oh, I'm having that issue with my slides not advancing. Not sure what's happening.
Try and go to the bottom right of your slides and see if it'll show you a little arrow. It might be on the left bottom, depending on your.
Is that, yeah, so here we go. Yeah, it looks like he moved over. So again, this is a labor and delivery at the Salima District Hospital. Having a bed is a luxury. In fact, in the birthing kits that they give women to bring with them when they deliver, it includes a trash bag. So they literally go out and get a black trash bag, because often when they come in, there's not enough room, enough beds for them to have labor beds. And so they will come in and actually lay their trash bag on the floor and have their babies. And this is just me. I was actually walking through the labor ward and I just noticed this woman that was on the floor. Essentially, the baby was coming out and I just sort of leaned over with one glove and delivered. So very crowded facilities, understaffed, under-resourced. This is one of the operating rooms that I've been working out of with a district hospital. So this district hospital actually covers a catchment of about 560,000 people in the Salima area. They have 2 little operating rooms. There's a minor operating room that you're seeing on the right side, and then the major one is the one on the left. That is their sterile room, and those are all the surgical equipment that actually have in that room. And you can imagine for C-sections, any sort of surgical procedures, that's all the basically hardware equipment that they have, for laparotomy sets, C-section sets. So, in looking at the cervical cancer statistics, again, this is just a comparison. We talked about how this is a 4th most common cancer of women in the United States. When you look at Malawi, about all the women in cancers, actually cervix cancer makes up about 45% of that. Comparatively, looking at the death rate, 51.5 deaths per 100,000 per year in Malawi compared to 2.2 when you look in the United States. And the 5-year survivorship overall is at 2.9% in Malawi, compared to, 67% out here in the United States. From diagnosis to death can be as short as 10 months. And so some of the approaches to cervical cancer that we usually look at over there, prevention being one of the biggest things as we're talking about in this setting, screening, how do we treat pre-invasive lesions, and then how are we actually going to treat cancer in this particular setting. So with regards to prevention, vaccines will be, a key factor in this, but there's some vaccinations have made it to Malawi in terms of HPV vaccines, but very limited access. Also Pap smears are very limited. Most places that are actually doing Pap smears are usually private hospitals that are not accessible to the, Malawian. Their mainstay there is what they call the visual inspections with acetic acid. And so that's what they usually use. Colposcopies and biopsies, all those things are limited because of the resources and also how to treat the pre-invasive lesions. We know vaccines work. And so if we were going to really tackle this in sub-Saharan Africa, this is what we would want to do. And we just, think about what happened with smallpox, a disease that literally, killed millions of people, over nearly 200 million deaths. But you could see once the, vaccines came in, you're going from, seeing so much red to a lot less red. And by the time you were getting into the 1980s, smallpox was pretty much almost eliminated. And as you can see over there, this is a group of people in Africa that had access to smallpox vaccine. And so why can't we do this with HPV? Some of this is related to costs, just sort of zooming in of where the HPV vaccine is like $250 per vaccine. And so these are some of the limitations. And of course, Pap smears and the pathology and getting HPV typing. These are all the things that, sort of like barriers to access and the disparities that we're seeing. So again, in Malawi, like we talked about, VIAs are the main form of screening. There's higher demands on time because they have to use acetic acid. They have to allow it for it to take. These patients have to travel from the villages to main areas where they haven't. A lot of the healthcare facilities that are in the rural areas, they don't even have the equipment or trained personnel. So you can imagine having a woman that lives in Salima, which is a very small town, having to travel either to Lilongwe or Blantyre to find where the equipment actually exists, or they have trained personnel that's very limited. And then, of course, the, costs of travel, and whether or not your clinicians actually have the, skill sets to be able to recognize invasive or pre-invasive lesions. And so these are sort of their approved methods of how you treat pre-invasive lesions. I would just sort of bring attention for these low, medium income countries. There are ablative therapies like cryotherapy and ablation of more the mainstream. And when you look more towards the US side, we see the excisional procedures being more the mainstream of this. And so, again, while ablation is available, it's also very limited and largely using cryotherapy and thermoablation. Excisional procedures are going to be limited to probably the higher care level centers, like if you go to Lilongwe at the Central Hospital or Blantyre or Mzuzu, but very rare that you can actually find people that are able to do excisional procedures in district hospitals and health centers. And so this just looks a little bit at some of the techniques that we use in terms of excision versus ablation. The key thing with excisional procedures, you actually get a tissue specimen. You can send it to the pathologist. You're going to be able to know, is there invasive cancer? Is it pre-invasive? You know what the margin status is. So while ablation procedures may be a little bit easier to implement, one of the issues is that you're actually not going to be able to get a tissue specimen. So, if the patient truly has pre-invasive lesions and there was nothing invasive, then you're probably okay. But if there's invasive disease, there are patients that probably get ablation for, cervical cancer that was not diagnosed because you don't have the tissue specimen. And so these are some of the criteria for, doing ablation. And that's also one of the limitations. You got to make sure the person that's seeing can actually know what is the squamous columnar junction. Are they seeing the entire lesion? You can only do this if less than 75% of the cervix is involved, because otherwise, if it's more than that, you probably want to more go towards an excisional procedure because there's a higher risk that there's cancer. And also making sure it's not extending further into the endocervix, because your technology is not going to be able to get into that, and also the vaginal walls. And so these are just some of the things that you want to look at. Who meets criteria for an ablative procedure, who doesn't? Again, the technique and the knowledge and the skill set of the person doing this would be the limiting factor, especially in the studying that we have in Malawi. So, pathology, this is also quite an issue in Malawi. I think the last that I checked, actual trained pathologists who actually went to medical school and became pathologists, they had 3 areas, and most of those are actually located in the major hospitals. They go and do like a training of some of the ancillary personnel, including some of the nurse practitioners and PAs. They call them clinical officers, and basically in a short amount of time, whether it's a matter of months, just train them to become pathologists. So cancer diagnosis can be very deadly, because sometimes from the time you actually get a specimen to when you get the answers, it could take quite some time. And it is essential, if we're going to be able to figure out how to treat these diseases, to be able to do that. So that's a critical missing piece as far as the Malawi situation is concerned. This is actually a surgery that we did on the last trip that I was in Malawi. We performed a surgery for cervical cancer on this woman. She actually had a pretty significant lesion, but usually here in the US for 1B3 cervical cancer, we'll do chemoradiation. They don't have the means for that. We did this surgery on June 26th, and the pathology report was sent to me on WhatsApp September 7th. Because they ran out of paper to actually print out the pathology report, they had to shrink down the amount of detail that they put on here, so that if I needed more details, I would actually have to call the pathologist and find out more information, because they didn't have enough paper to print 4 pages of the pathology report. When I do these procedures in Malawi, I actually pay out of pocket for the patients, because I work in the setting where most patients are coming from the village. It's $16 for people that make $1.25. That's cost prohibitive for them to get a pathology. So often they'll have something removed and they choose not to even have a pathology study on it because they don't have $16. And that's a subsidized cost, by the way, for the group that's UNC that are working out of Lilongwe in Malawi. So very limited training. So, staging again is going to be limited in a country where you've got a doctor-patient ratio of 1 to 50,000, with very few patients being able to see a doctor. There's very limited access to physicians, even general practitioners, and later on somebody who would be a gynecologic oncologist. And so, in the US, these are the surgical options for early disease. We're able to actually offer patients ability to get, surgeries. In Malawi, the gynoncs that are there were basically people that had some training in GYN oncology. I remember one of the ones I worked with at Kamuzu Central Hospital. He spent 2 weeks with a group that came from North Carolina, and there was also a group from Baylor. They came and spent 2-3 weeks with him and took him from being an OBGYN to basically becoming the central hospital gynecologic oncologist. I did 3 years of a fellowship to be a gynecologic oncologist after 4 years of OBGYN. So you can imagine when I went and I was working with him, he was the newly dubbed GYN oncologist there. He had no protocols, and most of what he's done, which is an incredible job that he's done to grow that program, has just been learning basically as he goes. Here we're so sophisticated, we're actually doing sentinel lymph node mapping and sentinel lymph node dissections for cervical cancer. And in Malawi, they're just even trying to learn how to do simple hysterectomies at the district hospitals. So for locally advanced cancer in the US, we have the option to do chemoradiation immunotherapy. Malawi currently doesn't have any radiation, no immunotherapy, and there's some limited chemotherapy. So in the backdrop of all this, I wanted to share a little bit personal part of it. So this is sort of like an area just outside of the village where I grew up. My family and I started a non-profit organization there. It's called Pothawira International. We actually have a medical facility there. The goal was to really focus on women and children, which is the most vulnerable population. And so, Safe Haven was founded, and the medical facility, the idea was to sort of start something that was a well-functioning health center where, you have sufficient human and financial resources, the essential drugs, and the necessary equipment to be able to actually deliver good care. In addition to that, we actually have a home style sort of care where there's actually women that take care of children that are abandoned or they're orphaned, which is very common in Malawi. Just large, like 36% of the kids that are in our orphanage, their mothers died giving birth. We also provide education, because I wouldn't be sitting here in front of you if I didn't have access to education. So we actually have a primary school where the kids that stay there with us and then kids from the surrounding village are able to actually attend school there. We're actually actively building a high school also, and this will also catch all the kids that are, staying there in this particular area, as well as, any children that otherwise wouldn't have access to be able to go to high school. So, and then this is a child development center that we have, just really focusing on the early education, because I really truly believe that the future of, countries like Malawi lies in the minds of the children there. So educating them, to me, is going to create more children that are going to become somebody like me, and they can actually be invited to seats and tables where big decisions are being made about, their countries and their families and their friends. We have a computer lab, and this has been groundbreaking for our kids because they're actually able to do some online schooling, even with some English curriculums from the United States. We have a sewing program. This is a real big empowerment program for the women there, as well as some of the younger girls that we know won't be able to make it to college, but they have a way to be able to support themselves, because we know the more educated they are, the more ability that they're able to, support themselves, the more access that they will have to actually good health care. We have gardens, this is all the sustainability projects. And then we also have a food processing center where we process the corn and the rice and then able to distribute it around to the villages there. So this is our outpatient clinic. We see about 200 to 300 patients a day. It's very, very busy. And we have about 42 staff that run it. And then, of course, we do have the visiting physicians that come generally with me every single year. We opened a birthing center. We had a little bit of a slowdown around COVID that we talked about. We've had over, 800 births, no maternal deaths. We actually had one intrauterine fetal demise. And so for a country where there's such high maternal mortality, it's amazing when you have adequate staff and equipment, and even something as simple as ultrasound to know where the placentation is. There's a picture there of a lady to the left that you see with the two of my friend OBGYNs. She actually was slated to deliver vaginally, and with a handheld ultrasound called a butterfly, we figured out that she actually had placenta previa. So this woman would have actually gone to the hospital, would have been trying to push her baby through placenta, and most likely would have made it. So we were able to make that diagnosis with a handheld ultrasound, took her to the hospital, performed a C-section, and she actually ended up with a C-section hysterectomy because she had significant bleeding. So, I know that woman wouldn't have made it if we hadn't happened to be there with that ultrasound. One of the things to improve access is we've actually we have an ambulance. This was a donation from a group of women OBGYNs that they did several years ago. We've actually had this for 8 years now. Because we don't have a 911 system, our patients actually can use cell phones because now cell phones are more commonly used even in the villages. So they call the labor and delivery unit that we have. They'll be able to tell us where they're located. So if they can get to a main road, we actually have our own little sort of emergency, because there are women that deliver on the road trying to, get to us. We have a waiting shelter so that for women that live very far, if they want to come close and just sort of camp out when they get to the last parts of their pregnancy, that's also available. So surgical services were a huge part of what we decided that we needed to add, because other than doing these normal deliveries, whenever our patients needed a C-section, we're transferring them to the district hospital that has one operating room. And so that means there are women that are actually literally having ruptured uteruses waiting for their turn to make it to that one operating room that covers 560,000 people. And just to give an example, I'm in Houston. My hospital has 25 operating rooms in just one. And there are 3 other major facilities that are just across the street with just as many operating rooms. And so then the vision to add surgical services came in, and this is just right outside of the birthing center. So October of 2023, we actually went in we got a grant from Deerfield. They're actually based in New York. And so October of 2023, I was actually there on the ground for the opening ceremony. And so where everybody's sitting there, that's the labor and delivery unit. And so just outside of that is where the surgical center is. And the idea was this would actually allow women to come right into their operating room for emergency C-sections. So, this is the most recent picture. So in just, in less than a year, we were able to go from October of 2023 to now this structure that you're seeing. So this is a major surgical center. We actually have 4 operating rooms in it. And like I said, you can see the birthing center there kind of towards the left. There's actually a direct entry from where the labor ward is, where you can just basically wheel, a stretcher. And the first room is actually the C-section room to allow the emergency C-sections, because that has been a devastating factor. Like I said, 36% of the kids in our orphanage, their mothers died giving birth. And so this is just sort of like an aerial view from a drone, just to kind of see the facility the way it actually looks right now. I actually just came back from Malawi 3 days ago. So we even further than this. At this point, they're doing all the internal finishes. We should be getting some of the equipment that should be coming in probably early this month and next month, and actually starting to put some equipment in. So the goal is to build a more comprehensive cervical cancer program, and we're going to start it at this facility as well as the local hospital where we've been working. And again, one of the key factors is to look at the prevention. HPV vaccination have to become affordable. We also have to create the screening tools, right? So there's other ways, the HPV self-testing. These are low-cost HPV testing. So if you're able to actually we know that during COVID in Malawi, they were able to do PCR. And so the technology is already there. So, just being able to figure out which patients have the high-risk HPV and you use your see and treat methods, will be a huge stride towards treating these pre-invasive lesions and really tackling the patients that have the highest risk of getting cervical cancer. And then, of course, the treatment of pre-invasive lesion, you can do the same day ablation. Like literally the patient comes in, you do the HPV testing, you do the, examination of the cervix, and immediately at the same time, go ahead and do the thermal ablations on your high-risk patients. And then obviously improving the surgical training and capacity, which is what's included with the OR. The idea is to actually start to bring physicians that will be able to perform these surgeries. I mean, we got to train people even to do simple hysterectomies, for high-risk patients, and then moving on to doing the radical hysterectomies. And we have to expand pathology. One of the things that COVID has taught us is that we can do a lot of things digitally and virtually. So, creating ability to be able to actually have pathology slides being reviewed by pathologists here in the United States that would volunteer their time to teach and to read pathology reports. And then, of course, in the future, the dream of being able to have radiation and more, availability of chemotherapy. So, I think engagement, we've been doing some engagement with, the, providers of the HPV vaccine to find a way to provide low or no cost vaccines to countries like Malawi and sub-Saharan Africa, because we know that vaccines work. And then again, we talked about the new low-cost HPV testing. Again, by figuring out which patients are highest risk of developing cervical cancer, you've got your PCR, it gives you the results. It's a lot less technical. And then which patients need more aggressive interventions versus which patients are more low risk. The thermoablation devices, and these are just examples of all the ones that are available that can be used. Sorry, that was too fast. One of the things that I really like about this is they've got this one where you can actually see and treat. You can even take pictures of the cervix as you're looking at it. You could use your iPhone to do it and actually send a real-time picture maybe to one of the OBGYNs and ask, hey, does this look like something that I should be concerned that there's cancer? Or do I think that this is okay to go ahead and, do the ablative procedure on it? So with a treating of the early cervix cancer, one of the things that we're doing right now actively at the district hospital, and this is us in the district hospital, is really training the local staff, like just even simple hysterectomies. A lot of them have some knowledge or doing some supracervical hysterectomies, and usually they're done in an emergency situation where like a woman is hemorrhaging and they have to take out the uterus. And so they're literally just chopping off the fundus. But when we're dealing with something that's cervical cancer, it's really teaching them how to do a complete hysterectomy to get down to the level of their cervix and maybe even take the upper vagina. So, so most of the trips that we've taken have just been even just teaching simple hysterectomies to make sure they understand that, and then slowly moving towards teaching how to do radical hysterectomies. So this is just one of the surgeries that we did when we were over there, a radical hysterectomy for a patient that had cervical cancer just this last year. So part of the goal is to build the surgical teams. The goal is to bring these teams from the United States, but there will be a collaboration where they will also be collaborating with surgeons there, people that are going to take the role of pathologists. So not only are they doing the procedures or the pathology or the anesthesia, they're also teaching who on the ground will basically create these teams, right? So we're going to build the teams from the US, work with, like we've been doing, work in Malawi, but also create comprehensive teams there. The idea is to literally work ourselves out of a job. I mean, I'll always be connected to Malawi. This is home for me. But I'm going to need to get to a point where I don't have to bring US teams, right? I can go there and there are Malawian surgeons and pathologists, anesthesiologists, OBGYNs, nurses, scrub tech, radiologists that are actually able to carry on with this. And so with treatment of advanced disease, one of the things we're looking at, which we see a lot of advanced cervical cancer, because again, lack of screening, lack of access to healthcare centers. So neoadjuvant chemotherapy is one of the things that's been, studied, where you actually give these patients chemotherapy, you shrink the disease because we don't have, radiation available at this time, and then do in vivo hysterectomies when the tumor is smaller and more amenable to surgery. Direct relief is a contact that we have with, pharmaceutical support. Global health collaborations. I just loved hearing, all, people that are researchers in the group. I think one of the things that we really love about academic centers is you've got young minds that are, excited about being able to bring innovations in education and research that's actually, useful in being able to implement changes that actually make sense in that setting. And of course, improvement of palliative care. One of the saddest things is you see these patients with end-stage disease, they're bleeding out, and there's no access to blood, or, the best pain medication that they can get is acetaminophen and ibuprofen. So just improved palliative care for end-stage disease. And of course, the future dream is being able to have radiation immunotherapy, which are these cutting-edge things that we have now in the United States. So this is just a picture of some of the support that we've been able to get actually from Direct Relief. They've provided us with midwife kits that have literally been life-saving. They include, cytotec that we use for postpartum hemorrhage, which is one of the #1 killers of women in Malawi. We've been able to get IV and oral medications. And so our goal is going to be to tap into them for chemotherapeutic drugs, because they have actually direct communication with pharmaceutical companies. And again, the global health partnerships, Northwell Health, who are based out of New York, we've actually started creating a relationship with them. We had one of their gynecologic oncologists who came with us last year, as well as a fellow that came along. So our goal is to continue to nurture that relationship and sort of create those global health collaborations with academic institution, and then Providence, which is based in Alaska, Anchorage. Money, 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 money. None of these things can happen without money. And that's one of the, I think, the fantastic things that you guys do as an organization. And I started as small as, we literally did a garage sale. That the land where this was built was actually from a garage sale that I did with medical school friends of mine. I was actually excited today seeing some of the medical students that are involved in things like this, because it's amazing what each one of us is actually able to do if you just tackle the people in your circle. I mean, it's a gift that keeps on giving, and so one of the things that I started as simple as like recruiting people to go climb Kilimanjaro. I've climbed Kilimanjaro 8 times. For fundraising efforts. But we're now evolving to where we're looking at organizations that are interested in tackling cervical cancer or maternal health, and actually applying for grants. That's how we're able to actually build the surgical center. And right now, we're actually in the process of trying to apply for a grant through Melinda Gates, to see if we can actually, get this cervical cancer program started if we're able to get that grant. And so, one of the things that I always tell people is like, sometimes when you look at the problems and the disparities and you walk into Malawi and you see the level of poverty, it can be overwhelming. And you think there's nothing I can possibly do here that can make a difference, right? I grew up in this village. I ran to school. I carried water on my head. I attended school under a tree. But I think it's a matter of all of us believing that there is something that we can do, right? You could be the first person that builds a school there. I have a picture of some young women that over there. So Ari is a daughter of actually one of my good friends who's a gynecologic oncologist. She actually came there with her mom and looked around, and we have that garden that you guys saw the produce from. And she realized, we had all these things that we can do composting. So at age 14, she was able to start a composting program, that's still ongoing. So we all have the ability to actually make a difference. And it's just a matter of kind of figuring out, where do we fit in and how do we make a difference in the community that we're in. So, it's really just about, making sure that our eyes and our ears are open. You want people to feel seen, to feel heard, to not feel forgotten, and to feel reached. And so, I think we have a large population of women, in these countries that are looking for us to reach out to them. Thank you for your time.
Wow, Dr. Alaniz, thank you so much. I, for one, am incredibly inspired by your talk just now. I'm going to open the chat for questions. I'm glad you tackled fundraising, because I was thinking about that the whole time too. And our chapters, they work very hard all the time. I'm sure if you could share some other great fundraising ideas, that would definitely be of interest to the leadership. I see Tracy. Lauren, if we can let her in, that'd be great.
Good afternoon.
Yes.
Hi, Tracy.
I'll go ahead and speak. I'm not sure if my video is catching up, but anyway, I'm curious if you could speak to any stigma that might exist in the Malawi culture. And what I'm referencing is what many of us know in our work here in the US, that when you start talking about STIs or anything related and that framing, it creates walls. So it's kind of a two-part question. One, is there stigma because it is sexually transmitted? And two, is your education methods there like more towards cancer or cancer prevention? Thanks for letting me just kind of mumble all of that out.
Yeah. So, I know like even with HIV for the longest time, there was even stigma around that because it was a sexually transmitted disease. And a lot of times with STIs, there is some stigma that goes with that because there's always, a thought that you must be promiscuous to have that. It started off that way with cervix cancer, but I think it's less of an issue in terms of like having a diagnosis of cervical cancer. The only part that I find it more culturally, women are very private about their private parts. It feels very much like you're still you know, in the 1900s, where you don't talk about your private parts. So I think the part that's probably more difficult is like when women go out into the community, they're not going to be raising their hands and saying, I have cervical cancer, I'm bleeding vaginally. In a hospital setting, they're able to discuss it. And often they would just say, you know, they had cancer. But in terms of actually having like communities shun women that have cervical cancer, no, that's not as much of an issue. I mean, we had that issue with like fistulas, and I have not seen the same response of the community in terms of, you know, that particular aspect of cervical cancer. So I think from there, you know, we really have a place to build on. We have more it's a society that's afraid. After the COVID vaccines came in and what happened with some of the vaccines, you know, there's a lot of skepticism around vaccines, that we're trying to just sort of inject Africans and kill them all, you know, and so there's probably more work to be done in convincing people the safety of vaccination, especially with HPV after the COVID experience. You know, but I think short of that, women are open to knowing how can they prevent cervical cancer, because most of them know someone who's died from the disease. And I think the fact that, again, 45% of all cancers in women in Malawi are actually cervical cancer. So someone knows someone who's died from cervical cancer. And that itself has actually sent us very strong message to women. And they're always looking for how do I prevent this, and how do I know what's going on? So our education for the community is based on prevention. How often should they be going to get their VIAs, and where should they go, you know, get those, and why it's important for them to invest the time and even their limited financial resources to be able to go do that. And then, you know, medically, for the medical community, it's really also educating about how they can get out to the community and discuss this with women, making it a comfortable subject to discuss, even though, you know, it's sexually transmitted. And then also to increase their own knowledge in terms of skill sets to be able to do adequate VIAs and treat patients. And then, of course, all the treatment. So it's a, sort of a multi-step, but right now, I think for us, the focus is really to really get the prevention and screening methods out. And then, of course, if you're going to screen and you're going to do prevention, you're going to catch cancer, you know, and so that will be graduated into, you know, how we're going to treat when we find pre-cancer and cancer lesions. But prevention, I think, is going to be the key.
Do we see any other questions in the chat? I do not. Dr. Alaniz, thank you so much for your time and for sharing your story. It was absolutely incredible.
Thank you for having me.
We're
I
lucky
appreciate
to
it.
have you here. Yeah,